Very good, thanks Otto.
Yes.
Move on to the next talk. So the next speaker is Suku Nair, and Suku started the first UK randomized control trial looking at the outcomes of minimally invasive aortic valve surgery. We certainly need more data to encourage the operation to move forward, so we'll be interested to hear your thoughts, Suku.
Thanks, Anok. Thank you for asking me to give this short update on the MiniStern trial. The Mini-sternotomy trial basically compares these two approaches, the full sternotomy versus right upper mini-sternotomy. Just going back, so this is a trial funded by the National Institute of Health Research for Patient Benefit Program. It is very helpful for surgeons to get funding from the NIHR. However, there are some restrictions placed. NIHR strictly restricts publication of results till the trial recruitment is completed. They do not allow detailed interim analysis. So what I'm going to give here is a brief overview of data which the NIHR feels comfortable publicizing. Currently, there are 2 sites recruiting. Freeman Hospital will start recruitment next week. Papworth Hospital has been the main hospital recruiting to the majority of these patients. My colleague, Mrs. Sudarshan, is the principal investigator at Papworth for this study. So my approach, this randomized trial compares between full median sternotomy versus a right upper sternotomy cutting into the 4th intercostal space. There are few slides just showing some still images of the approach of the mini-sternotomy. So we go by a 7 to 8 centimeter incision starting halfway between the suprasternal notch and the angle of Louis up to downwards, usually up to the 4th intercostal space. We use a vertical saw to make a J or a L-shaped incision of the manubrium. With a small retractor, the aorta and the right atrium is exposed, and we go for central cannulation. So we cannulate the aorta using a wired straight cannula, and we use a flat venous cannula for the right atrial appendage. With this, we ensure good uncompromised cardiopulmonary bypass. Cardioplegia is given antegrade as usual with an ascending aortic cross clamp. These were the days when I used to use a right superior pulmonary vein vent as well, but lately we don't use that. The valve is excised, valve sutures are placed, valve is sized as normal, valve sutures are placed, and the prosthesis is lowered in position, and we wean off bypass after confirming appropriate de-airing. So transesophageal echocardiogram is a must in these patients. Nowadays, I think it is standard of care in almost every hospital. After confirmation of, prior to removing the clamp, we place epicardial pacing wires, usually brought out through the 4th right intercostal space, and after confirming hemostasis, sternal wires are put in place and the chest closed. So why this trial? I mean, if you think about mini-sternotomy versus full sternotomy, there are potential benefits. You could say that in median sternotomy, you have a shorter operation time, I would say, minimal resource demands within the NHS. So theatre time is costed and counted nowadays in hospitals. It is a reproducible and time-tested approach, median sternotomy. And there is always the case of surgeon familiarity. Whereas mini-sternotomy, you could theoretically argue that it reduces sternotomy pain. Maybe patients recover quicker. And this should also be considered in perspective. Within the NHS, we know some patients stay in for non-medical reasons in the hospital. Patient satisfaction, of course, mini-sternotomy, small scar, patients are happier. But does it really result in a financial gain for the NHS? Does it really reduce postoperative bleeding? Does it reduce wound infection rates? And the theory, if you review the literature, there are some reports saying that minimal access incisions actually help to restore lung function postoperatively faster. Is that true? There are some risks you can think of. Median sternotomy might increase wound infection rate. can cause pain, worsens lung function, and delays return to active life, and might prolong hospital stay in comparison to mini-sternotomy. However, when you talk to your team in the hospital and you'd say that you've got a mini-sternotomy case to perform, and in general, when you talk about a big team, you have 6 or 7 surgeons, and performance varies between the team, between the members of the team. It can be technically complex. You need proctoring and specialist training to perform this. There might be an increased risk of paraprosthetic regurgitation due to limited access. Clinicians will say maybe you put a smaller valve to get away and finish the operation quick. Is there a higher risk of patient-prosthesis mismatch? All this are considered in this trial. So hopefully by the end of this trial, we'll have answers for this. It is a prospective, pragmatic, randomized controlled double-center trial. There are 7 surgeons involved, and I've listed my colleagues who have very kindly agreed to be proctored and now are recruiting into this trial. 7 of us. All first-time isolated aortic valve replacement patients are included, and there are some exclusion criteria. We decided not to include poor left ventricular function patients because we anticipated a slightly prolonged cross-clamp time. Maybe that will be detrimental to the interests of a patient with poor left ventricular function. Significant chest wall deformities and morbid obesity are contraindications. And of course, if you're doing concomitant procedures, we exclude them. We have had, in our initial experience within the first 10 cases, we had 1 or 2 patients who could not have a transesophageal probe inserted, and we consulted the NIHR, and their opinion we should exclude those patients, so we did. If we can prove, so thinking about the health economics of mini-sternotomy approach within the NHS, if we can reduce hospital stay by 1 day, then as per the 2007 data, we will save about £1 million per year for the NHS. The primary endpoint of this study is length of stay in hospital, because this was a research proposal we submitted to the research, Research for Patient Benefit program. We had to demonstrate a patient benefit as the primary endpoint. However, we also included the day of fitness for discharge because, as I said before, on many patients, day of discharge is delayed not because for medical reasons, but for social reasons within the NHS in UK. There are some secondary endpoints which we assess at 6 weeks, in hospital, and that is the ease of mobilization. So in this trial, the surgeons do not declare the day of fitness for discharge. It is the physiotherapists who do that. So of course, the surgeons will look after the patients post-operatively, but the physiotherapists assess the fitness for discharge from hospital. Therefore, time to first independent mobilization, post-operative pain levels are monitored using a PCA pump, and perioperative bleeding is checked and recorded. Secondary endpoints assessed at 6 weeks, 6 months, and later at a year include left ventricular function, the incidence of paraprosthetic regurgitation, and wound complication rates. Patient satisfaction and quality of life checks are also made at these 3 points. So, to calculate the number of patients required, we used the data from Papworth Hospital in 2007-8, when the mean hospital stay was 11.7 days for isolated AVRs. And using the statisticians' help, we came to the conclusion that to conduct a study with 80% power, we need 110 patients per group. So we need a total of 220 patients. So far, we have recruited 159 patients. This excludes the 42 patients which we had to not recruit into the trial, but use for proctoring 6 colleagues, of which 82 have had mini-sternotomy and 77 have had full median sternotomy approach. The age range, as you can see, is between 18 and 88 years, and we've had 131 tissue valves here. So majority are tissue valves in this trial so far. This trial is progressing and will hopefully finish recruitment in October this year. So So our expectation was to finish recruitment in 3 years. And why has it taken so long? The surgeons are very pro-trial. They are very good in recruiting patients into the trial. However, over time, over the last 5 years, we noticed that the percentage of patients requiring combined aortic valve plus another procedure has gone up. Therefore, our recruitment numbers were much less than what we anticipated. Morbid obesity with a BMI more than 35, as I mentioned, was a contraindication. And over the last 5 years, the percentage of patients we operate on who have morbid obesity has gone up as well. So these two factors contributed, partly, I think, in us not achieving the anticipated recruitment numbers. I'll touch on mortality. So far, we have had 4 deaths in the mini-sternotomy group and 2 in the median sternotomy. As you can see, 2 deaths in the mini-sternotomy group were not operation-related, but 2 you could argue were. So one lady had bowel ischemia on day 10. She was doing well till then, but then had a laparotomy, intestinal resection, but succumbed. And the 4th one was on day 3, the patient had cardiac tamponade, failed resuscitation, and died. This data has been run past the data monitoring committee, who felt that it was still safe to proceed with the operation, as all mortalities were not related to the approach. Apart from mortality, if you think about paraprosthetic regurgitation, which I have not included in the trial, there has been 2 instances of significant paraprosthetic regurgitation in the mini-sternotomy approach group. One happened in theater, and the patient went back on bypass and had a redo valve replacement, and the patient left hospital fit and well. The second instance happened, or for some reason, when we reviewed the echocardiogram, the paraprosthetic leak was there immediately after the operation, but the surgeon opted to ignore it. The patient came back 6 months later and had a redo operation. So there are 2 instances of paraprosthetic leak in the mini-sternotomy group, which was of clinical significance. When it comes to this sort of morbidity, the NIHR was not keen for me to present that data because they wanted recruitment to complete. If you think about this trial, why should this sort of a trial happen and continue? There are various reasons. It is still a very common operation performed within the NHS. If we can demonstrate patient benefit and benefit to the NHS by approaching the valve through a mini-sternotomy, then we should adopt that. Is this concept actually appealing to our patients? We had 783 patients screened so far. And if you exclude the 42 which we use for surgical proctoring and the 39 who are still in screening, only 45 patients actually declined participation in the trial. So only 5.8 actually declined participation. So the patients are quite keen to be part of this trial. However, we have found only 22%, about 22% of patients are truly eligible to take part in this trial, satisfying all inclusion and exclusion criteria. Just a brief review on literature published since 2009. The evidence is lacking. We still do not know the true answer, which justifies continuing this trial to completion. We need about 60 more patients, and hopefully by October, between the 2 centers, we can achieve that. These questions are still unanswered. We can say from individual surgeons' opinions and preferences that we know the answers to all these questions. But if you actually review the literature, these questions are still unanswered. When it comes to wound infection rate, incidence of paraprosthetic leaks, mortality, patient perception, relief of pain, etc., the answer, hopefully, we will have the answers by the end of this trial period. As Enoch said, it's one of the RCTs in cardiac surgery comparing 2 surgical approaches. It investigates all aspects of care. We had the data monitoring committee review all our data, and they have given us the go-ahead to extend the duration of recruitment for 6 more months and complete recruitment. Thank you.
Thank you very much, Suki. Having sort of embarked on this exercise myself recently, I really understand the pain and the difficulty of trying to run a trial like this. So I congratulate you on how far you've got so far and we look forward to your results in the next few months. Any questions from the floor?
Obesity, please, because I think, I'm biased. I do mini AVRs for nearly all of them now, but I think the obese patients have some of the most to gain from this.
Yeah.
Why did you exclude them, please?
I think it was initially when we drafted the trial, our assumption was that obesity would preclude clear visualization of structures. I partly agree with you because occasionally we have done patients who demanded mini-sternotomy, and there are only n equals 2. 2 patients have been done mini-sternotomy just because they demanded. They were both obese and excluded from the trial, and the surgery went very smooth and well. I agree that sometimes maybe obesity, it might be a mistake we made in the patient inclusion criteria. We could have included. In the start of the trial, I just want to mention this one. In the start of the trial, low respiratory function or a low FEV1 was included as a exclusion criteria, but very soon we realized that was a mistake, and we rewrote the ethics application and included those sort of patients. So nowadays, poor lung function is not a contraindication for this trial. I totally agree with you. Maybe we could have increased recruitment by including obese patients.
The other thing is, you're using, the 4th intercostal space, is it?
Yes.
Do you not think you'd show a benefit, or you might more easily show a benefit if you use the 3rd? Or some people, or the
Possible.
2nd?
I mean, Enoch and his team approach this through a upper manubrial split. So, I mean, yes, maybe that is better. I don't know. I have no experience doing that operation. Yes, David.
Firstly, thank you for a very honest appraisal of the trial so far for everyone. I was going to ask, the UK is quite a small country. Should we not have finished the MiniStern trial before starting another trial, and would it not have been better to go for more centres, because there were a lot of other hospitals with an interest in this way? I just feel, as a country, say someone looking from the outside, why we didn't get one trial finished in this sort of area and then move on to a second.
I think I'm the wrong person to answer that question,
yes, but there's other
because
people
the question is, I don't think that when it comes to developing ideas and writing grants and getting money to do a study, one center should wait for another center to finish the trial. Personally, I don't think. Yeah, but yeah, that's right. But the way the MiniStern trial was designed was to look at factors affecting other factors that could influence hospital stay after AVR. So it is not just the operation, it's also the speed with which, and whether this argument of quick discharge is really happening within the NHS. We all know many of our patients stay in hospital, not for medical reasons, for social reasons. At the end of the day, the National Health Service is paying for all that. So I take your point that maybe we should have included more centers doing this trial. However, to restrict other grant applications just because we haven't finished our trial is not the right one, in my opinion.
Can I comment, since I'm doing the other trial? I think there are a number of things really. Suku's trial looks at post-operative length of stay as the main outcome. And there are a host of different things to look at. We're looking at blood transfusion. You could arguably look at paraprosthetic leaks or death, etc., etc. So I think the first thing is that there are lots and lots of different questions to answer, and usually that means lots of different trials as opposed to one trial trying to answer them all, because usually that doesn't give you the best outcome. I do agree that going forward, large trials with multi-centers will be very valuable. But I mean, I think Suku and I have worked. I mean, it's very hard work getting money to get these trials up and running. We very, very rarely do them in surgery, and we very rarely do them in cardiac surgery. So I think just getting the sort of momentum and the experience amongst us as surgeons to do these trials will be helpful, because I'm sure you're right. Going forward, the right trials will be big, multi-center trials.
Can I just add one thing there? I think part of the reason you went down that road is that you were caught in this game of trying to get the funding by finding a kind of pseudo health economic basis rather than something that genuinely addresses clinical quality. I mean, certainly in the NHS, length of stay has got next to nothing to do with clinical quality. But unfortunately, if you want to get the money, you've got to pursue that sort of argument.
Sometimes you have to. But in this trial, we also are looking into very important secondary endpoints with clinical importance, namely the incidence of paraprosthetic leak and other wound complications, etc. So.
I suspect there's something powered to detect this reduction on a pretty long length of stay. I'm surprised at Papworth, but that was pretty long, 11.7 days.
I can reassure you that in that year, we looked at the STS database, and Papworth was one of the best. So whichever hospital, Andy, you're referring to, if you really look at the data, it's amazing. You'll be surprised.
I think there's a lot of myth. It's a bit like...
Yes. Sorry.
Can I ask you why you focused on paraprosthetic leaks? Because once you get this set up, valve insertion is just like a valve insertion with a full sternotomy. So why do you propose there's a difference? What's your mechanism against paraprosthetic?
Because one concern about, if you think about minimal access surgery in general, one concern we all have, or the community has, is about perfection of the job. So if you take minimal access mitral surgery, that is a concern. The concern is whether you can provide the patient the same quality repair as you would do with open approach. If you can address that, then you are justified offering that, in my opinion, to the patient. So the endpoint which assures a good valve replacement is a lack of paraprosthetic leak and absence of significant PPM, patient processes mismatch. So that is why, that was the logic behind using that. Yeah.
Another question?
Can I just make a small comment? I think I agree with my colleague there. I think one of the problems with minimally invasive aortic is that there's an obsession about the space. I think it's a wrong debate.
Yeah.
One of the things we've learned, we've done about 180 cases, is that the space, where you start, it doesn't matter. I think what we need is to start as low as possible. Apart from the cosmetic aspect, it gives you access to the right atrium. From my point of view, the ease with which you will perform this operation depends on the access of the right atrium.
Yeah.
Nothing else. The aortic route you can always access. And I think the idea that you start at the upper part of the manubrium, it's a wrong one. And using the space as a landmark, it's also wrong. So I think the paravalvular leak, in my opinion, it's a real debate, and I think it stems from the fact that when we start, we have a very difficult access, and yes, we had problems in the future. And one way of sorting it out, and have access to the aortic valve in an easy manner. And the best way we came out to have an easy access is to start as low as possible, use the same length and flat.
Yeah.
And we'll present that tomorrow.
Yeah. Yeah. Yes, Reza.
I think there's a very important, technical issue with any randomized controlled trial in cardiac surgery, which I think is valid for this trial. Can I ask, what is the learning curve for this procedure, and how many of the primary investigators or the trial investigators have actually negotiated their learning curve before contributing cases to this trial? Because there's going to be a criticism at the end that people who were on their learning curves contributed cases.
Yeah. So when we started this trial, actually, we thought that this is it's okay. I actually learned this technique from Mr. Amrani and Prof. Marjan Jahangiri in St. George's, where my rotation was. So I've watched and learned Mr. Amrani doing and assisted him as well. So when I started it in Papworth, it was fine, and then I thought about this trial and got colleagues doing it. And there were a couple of, at least 2 or 3 colleagues who felt that they were comfortable after 2 or 3 cases. Okay, and they started recruiting, and there were some issues, not significant issues, but unfavorable and unacceptable issues, at which point we stopped. We then discussed it with our statisticians, and we decided that this 2 or 3 is not enough, and we came to a conclusion, and that is not based on any science, and there is no evidence to base that on. We assumed a number of 6. So each surgeon has done 6 proctored cases with a fully signed off person before he or she starts recruitment. So that is why we have gone 42 cases. We have done 42 cases as proctored cases before recruiting. And this includes certain surgeons who have done these procedures elsewhere. Yet they all have gone through 6 proctored cases each.
Right, can I move the discussion forward and invite the next speaker up? And
Thank you.
whilst he's doing that, in answer to your question about learning curve, in Middlesbrough, we're presenting some data tomorrow that shows that the learning curve is about 30 cases for our operation. So 6 is quite an ambitious number, I think. So the next speaker is